Hypothyroidism is one of the most commonly missed diagnoses in conventional medicine. The failure often stems from how the symptoms present. They are diffuse, scattering across multiple physiological systems rather than clustering into an obvious endocrine profile. Look at this diagnostic data. Standard testing incorrectly diagnoses 48.5% of patients with subclinical thyroid underfunction. The TSH test measures the pituitary signal, not actual thyroid response. Furthermore, an additional 31.2% with slightly elevated hormones are improperly classified as normal. Correcting a slow thyroid requires mapping its systemic clinical phenotype. This means observing the physical manifestations of the disease across the body through 7 specific diffuse signs. Once the physical phenotype is mapped, the clinical intervention must bifurcate into 2 distinct pathways, depending entirely on whether the biological failure is driven by a metabolic bottleneck or an immune system attack. Relying on a single incomplete blood marker misses the complete picture. True diagnosis requires observing the mechanics of systemic cellular failure. Thyroid hormones regulate a specific cellular process by which the body manages fluid within the protein matrix of our connective tissue. When thyroid function slows, fluid gets trapped within structural proteins beneath the skin. This pooling causes morning facial puffiness around the eyes. This same swelling extends to the wrist, severely compressing the median nerve. This endocrine-driven compression produces numbness, tingling, and pain, widely known as carpal tunnel syndrome. In many cases, patients undergo mechanical surgery to release the nerve, while the underlying thyroid dysfunction goes entirely unexamined. Localized tissue swelling and nerve compression are entirely predictable downstream consequences of an endocrine deceleration rather than isolated anatomical defects. Lowered thyroid output also forces a severe deceleration in the body's overall metabolic rate. This systemic slowing directly impairs liver function. Sluggish cellular machinery fails to process incoming lipid molecules. As the liver's processing capacity slows down, its ability to clear circulating LDL cholesterol sharply declines. The clinical result is elevated blood cholesterol. Dietary fat reduction will fail to lower cholesterol because the root cause is a decelerated liver. This deceleration extends to thermogenesis, the production of body heat. When the thyroid fails to govern heat production, the patient experiences a persistent internal coldness, regardless of ambient temperature. The systemic energy deficit also affects the central nervous system. When thyroid output is insufficient, neuronal energy production in the brain slows down. This produces a clinical pattern of low mood, cognitive slowing, reduced motivation, and severe anxiety. The psychiatric symptoms are driven directly by neuroendocrine dysregulation. Looking at this clinical data, over 50% of hypothyroid patients present with depression as their primary clinical symptom. These patients are routinely placed on targeted psychiatric and cardiovascular pharmaceuticals to treat symptoms that are actually mechanical consequences of a systemic thyroid energy deficit. The systemic physical decline also presents structural indicators on the surface of the body. Thyroid hormones are required to directly fuel hair follicles. As seen here, when thyroid hormone output drops, the energetic activity within the hair follicle visibly dims and hair production stalls. The outer third of the eyebrow is highly sensitive to this decline. Thinning in this zone is a classic visual indicator of an underactive thyroid. Hypothyroidism also generates persistent tightness and spasm in the posterior neck muscles, a sustained mechanical tension that triggers chronic headaches and severe migraines. When a patient exhibits these structural and neurological signs, but standard blood panels return normal, a basal body temperature test provides a highly functional diagnostic tool. Place a thermometer under the armpit immediately upon waking, before any physical movement. Hold strictly for 10 minutes. Repeat for 3 consecutive mornings. An average basal temperature reading below 97.8 degrees Fahrenheit is a strong clinical indicator of glandular underfunction. Physical biomarkers and core basal temperature offer immediate functional evidence of true tissue-level metabolism that a standard pituitary blood test completely misses. If these 7 clinical signs are present, relying exclusively on a TSH measurement is unacceptable clinical practice. A proper panel requires measuring inactive free T4, active free T3, and critical TPO and anti-thyroglobulin antibodies. Testing these antibodies is essential because over 90% of hypothyroid cases are driven by an underlying autoimmune condition. This autoimmune majority is known as Hashimoto's thyroiditis. In this state, the immune system produces antibodies that actively and progressively destroy the thyroid tissue. The remaining minority of cases are non-autoimmune. These patients face a mechanical bottleneck in their ability to convert inactive T4 into active T3. This conversion process must take place primarily within the liver and peripheral tissues before the cells can actually utilize the hormone. Supplying synthetic hormone addresses the chemical deficit, but it completely ignores the progressive antibody-mediated destruction of the gland itself. This split-screen flowchart illustrates how intervention diverges. The baseline for both pathways is 200 micrograms of selenium, which converts T4 to T3 and reduces antibodies. On the Hashimoto's side, high-dose vitamin D3 acts as a master immune modulator. D3 requires cofactors like vitamin K2, magnesium, and zinc. The autoimmune protocol also requires gluten elimination to stop cross-reactivity, while the non-autoimmune clinical focus shifts entirely toward optimizing the liver's hormone conversion pipeline. Patients who have had their gallbladder removed suffer from chronically reduced bile acid, which impairs this precise conversion. Supplementing with bile salts after meals correctly restores the biological pathway. Iodine supplementation must be approached with extreme caution. Excess intake can paradoxically suppress glandular function and trigger an autoimmune response. Effective clinical intervention demands matching specific orthomolecular tools to the exact point of biological failure, rather than relying on blanket prescription strategies. Even with a perfectly calibrated protocol, full biological restoration will fail if systemic antagonists remain unaddressed. This diagram illustrates the active T3 pathway. Chronic stress elevates cortisol, and soy isoflavones inhibit hormone synthesis. Pharmaceutical estrogen introduces another barrier, while high-carbohydrate diets drive hyperinsulinemia, crushing the remaining metabolic flow. Removing these upstream suppressors determines whether a patient experiences partial symptom relief or achieves full physiological restoration. High-dose orthomolecular protocols, particularly those utilizing 30,000 IU of vitamin D3, require strict medical supervision and careful calcium monitoring. True thyroid management requires comprehensive calibration of the entire systemic metabolic engine.